You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Now, say for the athlete that is so unfortunate that they're playing soccer, landed completely awkwardly, ton of knee valgus and external rotation of the hip, and they did tear their ACL. What are some considerations towards, ACL, towards reconstructing an ACL? Do you have a specific graft choice that you use, or what are some of the things that are at the top of your mind that you want to make sure that you pay specifically, attention to in your female athletes?
Yeah, so you described obviously the classic scenario. So, 2/3 of these injuries are non-contact injuries. It's just, they happen during cutting and pivoting sports. So soccer, volleyball, basketball are by far the most common. And so when I see, the athlete in clinic for the first time, certainly I'm getting a detailed history and physical exam. If they're very swollen and stiff, I'm going to send them to physical therapy, and I'd get an MRI at that point because I have a very, very high suspicion for ACL tear. And then when I see them back, I would go over the MRI with them, talk to them in more detail about treatment options, and really more specifically graft options. So in a, teenage athlete, a high level athlete, there's really no question that we would do ACL reconstruction. And so then the discussion really comes down to what type of grafts, what are the options? What type of graft would we recommend? What does the athlete or family, do they have a strong preference based on, maybe the athlete already had an injury to the other knee, or maybe they have a family member who had an ACL tear and had it reconstructed. So it's helpful to kind of figure out where they are and what information they already have. But I would, in my younger athletes, when I talk to them about graft choices, I tell them about all the options. I tell them, first of all, about autograft versus allograft and explaining the differences between them. I tell them that in younger athletes, certainly I would advocate for using an autograft because there's a much lower risk of re-rupture using that graft in that patient population. And then within autografts, we have several options, right, which are all great. So, bone patellar tendon bone, hamstring autograft, or quad autograft. Now, BTB and hamstrings have been around the longest, or used certainly the most widely. Quad autograft has actually been around for quite a long time, but has not obviously caught on nearly to the extent of our other two common autografts, although it has become more common in probably the past 5 to 10 years. And for me personally, that is my autograft of choice. I really like the quad autograft because it's a robust and incredibly reliable graft. There's a ton of collagen, actually way more collagen than you get from the patellar tendon. You can, with the quad autograft, you could use an all soft tissue graft, which is my preference, or you can harvest it with a single bone plug from the proximal pole of the patella if you really do want to get that bone to bone healing, at least on one end of the graft. So it's very versatile, and you can use it in really any athletes. Some advantages over sort of BTB and or hamstring. I mean, with the quad autograft, you don't have the kneeling pain that you can get fairly commonly with the BTB autograft. And then the hamstrings, I mean, in young girls, right, the hamstrings can be tiny. And unfortunately, we really don't know ahead of time, like before the surgery, before we're trying to harvest the hamstrings, how big it's going to be. And so we are all well aware from the literature that if that graft, our quadrupled hamstrings, if they're not at least 8 millimeters, right, there's an incredibly high risk of re-rupture. And so I think, many of us would consider augmenting that with allograft. And then that raises the question, well, is that actually beneficial? Like, is that graft really beneficial? So that is actually one of the reasons why I personally transitioned from hamstrings to quad autograft. I used to do hamstrings. That was the predominant graft in my practice in the first few years. And then over the past 3 to 4 years, I've transitioned to using quad autograft because it's very reliable and it's just a really big graft. Patients tolerate it well. It does not affect their quad function, their extensor strength, their ability to return to play. Like, there are lots of studies in the literature supporting the efficacy of the quad autograft. And so I would really encourage others to consider using it, and for residents listening to try to seek out cases and the opportunity to get exposure to that.
Yeah, I know we've done a couple of cases using the quad tendon autografts. I think it's a pretty slick procedure. I like it myself. considering the sports, if I go into it, that may be something that I will may use in the future. And yeah, just like you said, it doesn't, at least the studies show it doesn't have, much, you still have good quad function afterwards, and you don't have that, anterior knee pain or that pain that you get with kneeling that a lot of, or a portion of the patients that have a patellar, a BTB autograft get. So that is a good option. And then just like you said, sometimes you can use a bone plug if you want, or you can kind of just do all soft tissue quadriceps tendon autograft. Now, do you have a preference for partial thickness versus full thickness autograft?
So I harvest, it's probably on average about 8 millimeters thick, but essentially I go down as deep as I can without breaching the capsule, without creating a rent in the capsule. And that's how I harvest every time. And it ends up being, like I said, probably 7 to 8 millimeters in terms of thickness. And then I'll usually harvest probably about 8 centimeters in length. And you can easily do that on every patient. There are lots of studies supporting the sort of average length of the tendon before you get to the rectus femoris muscle. So that's how I tend to harvest it. If for whatever reason, end up creating a small rent in the capsule, I just close that. So it is important to close that. I actually personally will close the whole defect from the harvest. And, at this point in time, I don't know of any studies that really show definitively either way, whether you need to close it or not. But you and I are investigating that. And so hopefully we're going to get the answer.
Give it a little bit of time. We will have an answer.
Yeah.